Hi, everybody. My name's Ken Steinberg. I'm the Vice Chair of Education for the Department of Medicine. Welcome to Grand Rounds. But before we start Grand Rounds, I want to introduce Bob Harrington, the Chief of Medicine at Harborview, who will present the 2025 Marv Turk Award. Bob, take it away.
All right. Thank you very much, Ken. Before we get to Dr. Schwartz's lecture, it is my pleasure to announce the recipient of this year's Marvin Turk Award for teaching, for excellence in teaching and patient care. Dr. Turk is a brilliant clinician and iconic teacher who was a faculty member here at the University of Washington for over 50 years. And first, a few words about Marvin. He is a Chicago man, born there in 1934. He completed his undergraduate work at the University of Illinois in 57, and then somehow graduated from the same medical school only 2 years later. I don't understand that, but it doesn't surprise me. He came to the University of Washington in 64 as assistant professor and was full professor only 7 years later in 71. Dr. Turk served as the chief of infectious diseases and then chief of medicine at Harborview, and also served as vice chair for the department and associate dean for the School of Medicine. Marvin was awarded the Distinguished Teaching Award so many times the department finally decided to rename it after him. His early investigative career focused on gram-negative pathogens and urinary tract infections, and of his first 30 publications in the 60s, 4 were in the New England Journal, 5 in the Annals of Internal Medicine, and 1 in JAMA. And here's just a photograph of some of those journal articles. You can see some other notable University of Washington faculty on the as co-authors, Dr. Petersdorf among them. So Marvin was a master clinician, a brilliant diagnostician, a pretty good dresser. You can see him there looking smart with Mary Fielder, and a genuinely cheerful and good person. He was also the teller of really awful jokes, just terrible jokes. But he wove medical education into those jokes, and it put people at ease and made it easier for them to learn. That really is maybe Marvin's greatest legacy, is the way he taught medicine. This is a list of the previous awardees of the Marv Turk Award. And this year, for outstanding contributions that have enhanced the traditions of teaching and patient care in the Department of Medicine, this award celebrates Marvin Turk, whose energy, enthusiastic teaching, remarkable clinical knowledge, humor, and support for students, residents, fellows, and faculty inspired trainees and faculty for decades and helped set the standard for teaching excellence, making our institution a place to learn, an outstanding place to learn. And in the tradition of what did it take you so long, this year's winner is Dr. Andy Lux. Congratulations, Andy. And then a few words about Dr. Lux. He received his undergraduate education at Duke, then furthered his education in political science at Stanford before switching tracks and getting his medical degree at UC San Diego, then coming to the University of Washington, where he was a resident and then chief resident, and then pulmonary critical care fellow, and then assistant professor, and like Dr. Turk, rose to the rank of full professor in just 8 years. I'm grateful that Andy attends primarily at Harborview in the MICU and at the trauma surgical ICU. He's been voted a local top doctor too many times to count. He is an expert in pulmonary physiology and high altitude medicine. In fact, he's the associate editor of the High Altitude Medicine and Biology Journal. He is a chair or co-chair of multiple medical student courses, and he's the program director for the Critical Care Fellowship. He also is associate medical director for CPET. I don't know what CPET is, but I'm glad that he directs it. And if you don't read the entire high altitude medicine and physiology textbook that he's holding here, Andy also authored a recent review of high altitude medicine in the New England Journal that is really a fantastic review and worth a read from everybody. Andy is a remarkable teacher. He's won the Excellent in Teaching Awards of multiple different types of award multiple times. Also, the Paul Beeson Award for Outstanding Clinical Teaching that's awarded by the residents, the Basic Science Distinguished Teaching Award by medical students, and he is a designated teacher superior in perpetuity. The accolades that people use when describing him are on the right: excellent, amazing, exceptional, phenomenal, just an incredible teacher. He is also a Duke fanatic. He is a Blue Devil, and he has no interest in the University of North Carolina Tar Heels whatsoever. I'm sorry that Duke was bumped out of the tournament this year by the University of Connecticut, but they have a strong program, and I expect them to be back next year. And he is also a tough mutter. This is some photographs I think Trish may have shared with us of him braving the wilds in some canyon. And I'm not sure what he's doing on the right-hand side, but I'm glad his back is to us. You can see that he gets into his work. And apparently he loves pretzels. I think they're kind of a Spartan treat, nothing sweet about them, which I think fits with Andy's persona. So if you ever have some pretzels on your hand, you've got a friend. So this year's Marvin Turk Outstanding Teaching Award 2025 is Dr. Andrew Lux, Professor, Pulmonary Critical Care and Sleep Medicine. Hearty congratulations, Andy. It was well-deserved and too long in coming.
Yep. Oh, excellent. Thanks, buddy. Yeah, so for you. All right. Very quick if you want to. Yeah.
I'll be very brief. Marvin Turk was actually my first attending physician when I was a resident. And so it's really an amazing honor for me to get an award that is named after him. I will say very quickly, every day I work from my office to when I attend in the ICU, I walk by the pictures of all the Harborview recipients of this award, people like Bob Harrington, John Sheffield, Michael Kopis, Dave Pearson. And I can't tell you how much it means to just receive an award that all these people have received, because they're all people that I've looked up to a tremendous amount over the years and learned a lot from. And then finally, I'd be remiss if I didn't thank two people before this ends and we get over to Grand Rounds. The first, I need to thank Rob Glennie, who is my division head for the first part of my career. Rob was instrumental to my success. He knew I wanted to be an educator from the get-go, and it was not a path that had been well worn at that point in our field. And Rob gave me the flexibility and the support to make it happen along the way. I'm grateful for that. And then I obviously have to thank Trish. Many of you know she's my partner. She's important to me and valuable to me and incredible to me for so many different reasons. But I'll just say from the standpoint of teaching and what made this award possible, she herself is a legendary teacher. I think she's a better teacher than I am and will ever be. And that always inspired me to try to up my game in the education world. And then, as anyone who has ever worked with Trish knows, she loves feedback. And she always gave me lots of feedback about my teaching and pushed me to be a better educator. And I kind of use that as a motivation all the time to just be better, whether it's teaching in the unit or teaching in the classroom with the students. So to Trish, obviously, thanks so much. And thanks to everyone, and thanks to my colleagues for coming today. I greatly appreciate the support. So,
Congratulations. Great. And with that, I will turn things over to Dr. Gitanjali Chander, the Division Head for General Internal Medicine, to introduce our Grand Round speaker. All yours.
While we're pulling up the slides, I'll just say it is today we are honoring Dr. Roger Pecoraro, and this is our annual Pecoraro lecture. Dr. Pecoraro was a GIM faculty. He passed away at a very young age of cancer and actually was a trailblazer in diabetes research. So I'm going to just tell you a little bit about him before I introduce Dr. Schwarz. Dr. Pecoraro fundamentally reshaped how we actually prevent diabetes-related foot disease. I'm not sure if any of you all know that. He, prior to his time, actually, when people had diabetes-related foot disease, amputation was inevitable. He actually was asking really important questions. Why do ulcers form? Why do they progress? How do we stop the pathway that leads so many patients to amputation? His landmark model described the progression from neuropathy to ulceration, infection, and ultimately limb loss, and became the foundation for modern limb preservation strategies. He also helped pioneer some of the earliest prospective studies identifying who is truly at risk, giving clinicians practical tools to intervene earlier. But perhaps the most powerful part of his legacy is the real-world impact. Through structured prevention and early wound care, his work contributed to measurable reductions in amputations. In fact, his pilot study reduced them by 20%, and set a new standard for diabetic foot programs. He really defined this field. And when he passed away, the Division of General Internal Medicine, I think this was in the early 90s, established the annual Pecoraro lectureship. And what we really try to do every year is bring in trailblazers in general internal medicine. You may remember last year we had Dr. Kimberly Manning, and this year we have Dr. Bimla Schwarz. So I'll just tell you a little bit about Bimla, and then she will talk about acing the Safe Prescribing Challenge. So Dr. Schwarz is a distinguished general internist, clinician scientist, and national leader in women's health and primary care research. She's a professor in residence and the chief of general internal medicine at San Francisco General Hospital at UCSF. She's devoted her career to advancing evidence-based, patient-centered care at the intersection of primary care, reproductive health, and health equity. Her research portfolio spans maternal health, lactation, and long-term cardiovascular outcomes, contraceptive effectiveness and safety, medication abortion, and reproductive health care for patients with chronic medical conditions. Her work has directly informed clinical guidelines, health system practice, and public policy. She's authored more than 200 peer-reviewed articles, including those in JAMA, Annals of Internal Medicine, New England Journal of Medicine Evidence. She also has held numerous national leadership and advisory roles. And she was recently named a distinguished professor in women's health by the Society of General Internal Medicine. She's deeply committed to mentorship, training the next generation of primary care researchers, and translating research into meaningful improvements in clinical care, particularly for populations most affected by health inequities. So we're fortunate to have her with us today, and please join me in welcoming Dr. Schwarz.
So thank you for showing up in person. I want to say I don't take that for granted. And I'm particularly appreciative they're not even giving you free lunch. So this is just a whole other level up. Thank you. And to all of you who are online, I hope you're getting some work done at the same time. We know how that goes. As you saw in my slides flashing through a couple times, I have no financial disclosures to share with you. And what I wanted to talk about today, with the goal of trying to make this as relevant to those of us who practice clinical medicine as possible, is a question that I get asked by house staff more frequently than others. And that question is, how do you feel about ACE inhibitors for young women? And I feel like when the residents ask me, it's always this question of like, they don't want to get on the wrong foot with me. They're thinking I probably have strong opinions, and they've run into people with strong opinions and they don't quite know how to move forward with this. So what I'm hoping I'll give you is a framework for how to approach questions like this. And one part of that is to just embrace the complexity and say, this isn't a black and white question answer type of situation. As I say that, I want to just put out some additional disclosures that I just generally embrace complexity. And I know that gender, sexuality, and family planning are inherently complex. And if at any point I give you the impression that I don't realize that some considering pregnancy do not identify as women, I apologize. I also recognize that not every person who is pregnancy capable wants to become pregnant at some point, but many do. And so that's going to be the main focus of the conversation today. I also recognize some become mothers without being pregnant through adoption or being a step parent. And I recognize that some carry pregnancies without becoming mothers, either because they have an early pregnancy loss, they have an abortion, or that was the plan from the beginning. They had signed up to give the gift of a surrogate parenthood. I should also say I love feedback, and I'm delighted there's some experts in feedback in the room, so bring it on. My objectives for this talk are to help make sure we are able to identify unique considerations when prescribing medications to women of reproductive age, to be able to effectively advise our patients on teratogenic risks, and to make sure you feel comfortable counseling patients on the comparative safety and the effectiveness of the options that are available to them to prevent birth defects. So all of that is within the context of the way I think we should practice all the medicine we do, which is trying to make sure we're providing high quality healthcare, which has been defined as doing the right thing for the right patient at the right time in the right way to achieve the best possible results. Sounds simple, but it can be complicated. So I want us to think about one of our young women veterans. We have women veterans. We have a growing number of women veterans in this country. 32-year-old woman. She's had one prior pregnancy that she terminated. She's had diabetes for the last 4 years, not well controlled. Her A1C is 9. She's not a smoker or drinker. On physical exam, you note her blood pressure is running high. She's got a BMI of 31. When you're doing your diligent foot exam in honor of Dr. Pecoraro, you notice she does in fact have decreased sensation of that monofilament. And so I ask you, how do you feel about an ACE inhibitor or an ARB for a young woman with poorly controlled diabetes and hypertension? So let's get a show of hands. How many are in the I would never prescribe camp? You know you're out there because nationally, young women are much less likely to receive these medications than other patients. How many try to avoid? Oh, come on. Last night, I had brave people in the audience. They raised their hand for every single option we gave. We've got some probablys, some always. Anybody in I might? What's the issue? All right, good. So for those who are like, what's the issue? The issue is that they carry these black box warnings saying ACE inhibitors should be avoided in late pregnancy as they might cause renal failure and lack of skull development in the baby. So does that mean any woman might be pregnant at any time and you should never give it in any situation? Or how are we going to think about this? And so I would say, as we think about safe prescribing to young women, we want to think about counseling about pregnancy risks. We want to think about advising on the birth control options. And because so many of our patients with chronic conditions end up with anemia, we need to think about the ways that some of these formulations are going to be impacting menstrual management as well. So I would say those are the 3 pieces of how we're thinking about this that I want you to think about. But to remember that all of these things are preference sensitive conditions, and you're not going to make this decision on your own and get to the right answer. Every single piece along the way is going to require an understanding of how your patient thinks about the risks and benefits here. But in order to have this conversation, we have to really start with what I would argue is one of the hardest questions for internists to ask, it seems, which is, would you like to become pregnant in the next year? Is this anywhere in the universe of possibilities that would feel good to you or not? Because this is going to be a fork in the road for us. If this is somebody who would say, yeah, I'm trying to get pregnant, or if I did end up pregnant, that would be a welcome surprise, then we're going to have to think about the risk-benefit balance in one way. And if it's somebody who's like, no way, no how, it would be the worst thing possible, please prevent it at all costs, then it's a very different conversation about how we're going to solve that problem. When we're counseling about pregnancy risks, We want to think about the risks to the mother. We want to think about the risks to the baby. And I would say we can't forget the risks to the father as well, because family planning involves multiple agents. And as I say that, I always think back to a patient I admitted once upon a time when I was an intern. He was an older man. It was late at night, and I was taking him up to his room, and he's like, "It's really hard for me to be here." And I was like, "Yeah, it's hard for me to be here too. I've been here for 36 hours." But I didn't say all that out loud. I said something like, "Yeah, it's really hard to be here when you're sick and not feeling well." And he said, "No, the last time I was here, my wife died giving birth to our son. And our baby son died too." And I was like, whoa, that is not what I was expecting about why this man had avoided healthcare for like the last 50 years until it was finally too much. So I think we have to think about the ways in which these decisions about what we're doing to protect the woman's health and the pregnancy can impact the men we're taking care of too. That being said, as we spent some time talking about with those of you who had the entertaining opportunity to join me last night, pregnancy has been referred to by some as the original stress test. It is something that puts a lot of strain on a woman's cardiovascular system, and maternal mortality risk is going to be highest for patients like this patient that I presented to you, who we can identify multiple places where she's going to be at vascular risk. We also know that here in the US, we have very distressing maternal mortality rates. These are dates showing how the US compares to some of our other countries, and it's not something that we should be proud of. Beyond that, we have very distressing racial disparities, and Black women in this country, shown in red on this graph, are much more likely to die of pregnancy-related complications than women from other ethnic backgrounds. And I didn't update this slide for you, but the more recent data hasn't changed, unfortunately. This is one of those things we need to do some more work on. So what all do we need to do? There's a whole lot we need to do. And I put this up again just as background to say, I am mindful of the ways in which racism and all of these other isms impact reproductive justice in this country. And I want us to like hold that in the background and think about what we can do to move that on. And then say, let's come back to what we're doing in clinic about like, how do you feel about an ACE inhibitor today or not? And within that say, there is really no such thing as an unexposed fetus. What we get to do is choose either between fetus being exposed to maternal illness or the risk of treatment, but hopefully not both. And that within that, we know that pregnancies in the US are frequently exposed to medications that have been labeled as teratogenically risky. Those risks are always going to be greatest in early pregnancy, before many are aware that they may even be pregnant. When we look at these numbers, this is something we've known about for a while. Maybe there's been some change over time. When we looked at these numbers in 2006, 1.86 of every 100 pregnancies in the US was exposed to a definite teratogen. More recent 2017 data, that had come down to 1.24. But some of that may be that we also just stopped calling things definite teratogens and we called more of them potential teratogens. And you can see the number exposed to potential teratogens increased. How do we think about a pregnancy being exposed to a potential teratogen? I would say this is one of those things where it's really helpful to have a lot of conversations before that information is needed. We're going to continue our audiovisual entertainment by moving more rapidly. So our energy saving, we'll have the lights go back on. Do we also document that we've done any type of counseling around things involved or provided any type of contraceptive services, which I'm going to give you a pass on. Like if you've provided contraception, maybe you can shortcut around talking about these risks. But if you want to be counseling people about these risks, I would say there's a couple of pro tips for how to go about this. You want to make sure you're talking about absolute and not relative risks. And this can be hard for us because
A lot of the literature in trying to get things FDA approved likes to talk about the relative risks because those numbers always look bigger and somehow more impressive, but they also sound a lot scarier, right? And we want to make sure we're talking about positive and negative frames. I'm going to give you some examples in a second if you're not sure what I mean by positive and negative frames. Using pictograms can be very helpful because in many settings, I work in a safety net setting, so particularly in my setting, but in many settings, our patients' literacy and their numeracy, their ability to understand what we mean when we're talking about a probability, is less than it would be otherwise. And then we want to consider, as I said previously, the risk of untreated disease and keep these things in the perspective of risks of other everyday hazards that people may have agreed to take on without thinking twice, like what's your risk of death while driving in a car. So what do we know about ACE inhibitors? And I would say, as best I can tell, we're mostly using ARBs these days as first line, and the data is fairly similar. So I liked my acing the challenge of the test, but if you want to just talk about ARBs, that's fine too. So major malformations in the best of situations affect about 3% of all US births. Your absolute risk of malformation after taking an ACE or an ARB in early pregnancy goes up to about 7%. So if you put a positive frame on that, most infants were healthy. 93 out of 100 infants were healthy, right? 7 out of 100 were not. And depending on how you feel about that, you may make different decisions about how you want to move forward. What you don't want to be saying is that pregnancies exposed to these medicines were over twice as likely to have that outcome. Because it can be twice as likely if that's 2 out of 10, 2 out of 100 versus 4 out of 100, 2 out of a million versus 4 out of a million. And those are really different risks for people to wrap their heads with. So that's on the pictogram, the difference between 3 and 7. And again, you can see most of those pregnancy outcomes were healthy. If we're looking at the risks of untreated disease or poorly controlled diabetes, again, hyperglycemia in the first trimester puts your risk of birth defects up close to 19%, meaning 2 to 9-fold higher risk of birth defects than we're considering whether or not we use an ACE inhibitor. And so does that mean if you have poorly controlled diabetes, you can't get pregnant? No, that's not the conversation we're having, right? We never want to tell our patients you're too sick to get pregnant because it's a very personal choice. And these are very personal decisions about this is the time, this is when we have to do this. It's just that if it is the time that we're going to move forward with this, we're going to need to monitor things a lot more closely. The reason you don't want to tell people you shouldn't do this is because when they hear you shouldn't do this, then they say, oh, I better not tell my doctor I did this. It'll just happen by accident, right? That's your worst possible situation where they're at risk, but they're not getting the close follow-up or monitoring that they would benefit from. That being said, most American women don't spend very long trying to get pregnant. If you do this out on a timeline, we see that the typical American woman spends about 4 to 5 years pregnant, postpartum, or trying to conceive, and on average about 30 years trying to prevent pregnancy. So if you're just doing it by the numbers, the patient in front of you is probably not trying to get pregnant today, but that doesn't mean you can take that to the bank as something you're sure of. When we asked in a large primary care practice, are you currently pregnant or trying to become pregnant as part of our welcome intake form? So it was just something we had of all the patients coming through. 7% end up telling us, I wouldn't mind being pregnant, I'm trying to get pregnant, or I'm currently pregnant. So that being said, see if you're any braver on this one. What proportion of US women of reproductive age experience an unintended pregnancy each year? 1%, 2.5%, 5%, 7.5%, 10%. It depends. It depends. People are probably actually the winners, but these are the numbers based as federal poverty level breakdowns. If you work in the safety net like I do, it's 10% a year. It's quite high. Nationally, it's 5%. Again, this data is old, but unfortunately, the curves haven't moved. Big differences in income, and that has to do with access to healthcare and access to how effective the contraceptives you're using tend to be. When we're thinking about trying to prevent birth defects, I want you to think about this as different types of prevention, the same way we think about primary prevention of other conditions. We have lots of options for contraception. We have secondary prevention, postcoital or emergency contraceptive options. And it's important for us to be writing prescriptions for ulipristal acetate, tends to be twice as effective as the over-the-counter emergency contraception, Plan B pills. And then we have tertiary prevention, prenatal screening and abortion. So it is not a crazy thing for a person to say, you know, I've heard you say that there's a 7 out of 100 chance that this could end up in a situation where the pregnancy would be affected, but that sounds okay to me. I want to go forward. I want the benefits of what this medicine can do for the rest of my life. But I would say at this point, I have lived far too long listening to patients tell me, oh, birth control is not safe for me. I have heard that twice from people who have been admitted to my service with a recurrent pulmonary embolism because they got put on a blood thinner and their periods were miserable and nobody helped them manage their periods, and they figured out how to manage their periods themselves, which was to stop their blood thinners, which is not what we wanted them to do, right? And, you know, one of them ended up on oxygen for the rest of her life. And so what we need to do is be able to make sure we're managing all of these things for our patients. And if we have any concerns about whether or not birth control might be safe for you, your taxpayer dollars at work have put together the CDC medical eligibility criteria. In some neighborhoods, this is old news. How many of you already have this app on your phone and you're like, been there, done that? If not, I would say you can download the app and have this on your phone. You can also have one of these charts if you're a paper person who wants to carry this around with you. But basically, it's like every condition you might worry about and every contraceptive you might worry about. And one of the big takeaways is almost everything is green, and green means green light, straight ahead, don't worry about it. Red is red light, hold up, worry about it. And there are some things that are reds there. Those are going to be the estrogens with things that cause thrombotic risk. So people like our diabetic patient with end-stage end organ disease showing would worry about that a little bit. Try to get her options. But also want you to be taking away, we have lots of forms of birth control that don't have estrogen in them. So you can't start the conversation with the only thing I have is an estrogen-containing pill and feel like you've done your job. And one of the things that just some version of breaks my heart and fires me up and makes me just feel really pissed off about the state of our world is that diabetic women go to the doctor much more often than non-diabetic women, but they receive contraceptive counseling half as often as non-diabetic women. And they're much more likely to undergo an abdominal surgery than get other forms of contraception compared to non-diabetic women. And we've just established this woman has all sorts of comorbidities. Why are we taking her to the OR if we haven't fully explored all our other options? So I want to encourage you to think about how many categories of birth control do you discuss with your patients? Are you part of the large group of internists who are just saying like, oh, I trust my patients are taking care of that. They go to the gynecologist if they need to. I would say that is the default in this country, and it's totally unacceptable. There are also folks who are like, oh, I'm good with my ABCs, courage abstinence, get them condoms or a birth control pill. That's my repertoire. There are some who can say, I get my patients to go look at this bedsider.org app. And bedsider.org is a good resource. I would say if you're not using it, it's a good one to try to use. It's not pharma sponsored, and it does talk about all of the options. And for those who want to discuss all 18 options, I would say there are many for us to be thinking about. And I would say try to make sure you've kind of gotten yourself some version of familiar with all of these so you can talk to your patients about things they can use before sex, during sex, and after sex, because all of these are options and people need to know all of their options in order to find what's going to be best for them. For many of my patients with chronic conditions, what we really want to know is which are those estrogen-free options. And again, there are many estrogen-free options, and I'm realizing another thing I didn't update the slides on. Nexplanon has now updated their label. So Nexplanon is labeled for 5 years of use at this point. It is the most effective form of contraception you can offer someone. It's absolutely an internist's procedure. I attend on the inpatient service, and I would say I put in one Nexplanon every week I am working inpatient, because women who need to be hospitalized tend not to be at the ideal point to become pregnant. And most of them are very happy to have a safe and convenient option to prevent pregnancy. We talked about bedsider. This is a screenshot. You can see how cute their stuff is. And there's lots of things we should be talking about with our patients in terms of what matters to them, in terms of thinking about what might be most important to them. I have liked bedsider's work for a long time, but it is very much developed for and oriented towards a teen audience. And I mostly take care of patients who are not teens. They're mostly people who are later on in their lives. Got my reminder at the bottom that IUD self-removal is safe. And so just to put that out there, if you haven't felt like you've been trained how to remove an IUD, I'm going to tell you now, you're being trained now. You just find the threads, tug gently, and out it comes. And that's a procedure that you've now been signed off and are able to do for anybody who wants help doing that. And that women can do that themselves. If they can find the threads, if they can tug gently, they can remove the IUD. So the other thing I wanted to share with you is a website we've developed. We call it the Advancing Access website. And we developed this because though bedsider is great, it wasn't really answering the questions that my patients were asking, which was mostly around like, I'm just done. I'm thinking about having a surgery, think about having my tubes tied. That is the most common form of contraception used in this country. We have more people who have undergone surgery than are using any other form of contraception in this country. That probably has something to do with the way we finance healthcare in this country and the fact that surgical procedures get reimbursed more than these other contraceptive procedures. Because if we look globally, we do a lot more of these sterilization procedures than Europe, for example, does. But if you have questions about how to compare long-acting reversible contraceptives to these surgeries, that's what this Advancing Access website can compare for you. And one of the things that it tries to make clear is that if you're looking for the most effective form of contraception, that's not actually going to be a surgery. Again, the most effective form is going to be that arm implant. And I hope you guys have all been trained to do that. We train all of our interns, and it's part of their routine training. It's basically like placing an IV, but you don't have to hit the vein. And then just to be further clear, when we look at the complication risks, whether that's infections or bleeding, placing an IUD is going to be like, I know I said we're not going to talk about relative risks when we're talking with patients, but because you're clinicians and you're used to this, relative risk of 10 times more likely to cause an infection if you put somebody through surgery, and 20 times more likely to have a bleeding complication. The other thing that we don't talk that much about is how likely our patients are to end up with chronic pelvic pain. There's been a lot of discussion in the lay media about how people may have pain with IUDs that they didn't anticipate and they felt they weren't fully counseled on. But I think we also need to be honest that there are a lot of people who end up with pain after having pelvic surgery to have a tubal ligation. And this is a study we did looking at Medi-Cal claims data. And clearly on the day of the procedure, you would expect people who had surgery had more pain, but this is looking out months and even a full year later. And 1 year after their procedure, people who had a tubal surgery had 9.6% of them going to the clinician with a code for having pelvic pain compared to only 6.2% with the IUD. So for a long time, I used to try to get people to remember that an IUD really stands for the internist's usual device. If they have a chronic condition and they need to see an internist, they would probably do really well with an IUD. Gives them effectiveness that is higher than if they went through a tubal surgery, and it's got no risk of blood clots, so none of these estrogen side effects we worry about. For those who have been practicing for a long time and think they have some memory, didn't IUDs increase your risks of PID? No, that's been laid to rest. It's actually chlamydia that causes PID, and the early studies didn't know how to test for chlamydia. But once you test for chlamydia, you see it's chlamydia that causes PID, not the IUD. And in fact, when you remove an IUD, you have rapid return to fertility, again, with this option of self-removal. I've given up on getting all internists trained to place IUDs. There are a number of folks here in your neighborhood who I know are internists who've joined the club of being able to place IUDs, but Nexplanons are definitely things that all internists should be able to offer. It's at least as effective as surgery. It doesn't have estrogen, so it's not going to cause any blood clots. It's been radio opaque since they rebranded the Implanon as Nexplanon in 2010. It's effective for 5 years. It's a really great option. Discontinued most commonly due to concerns of spotting, but that discontinuation rate is below 20%, which is much better than we get when we give people birth control pills. 50% of them discontinue within a year. Just out of curiosity, so I know in this room, how many of you were trained to place Nexplanon in the last year? How many 1 to 5 years ago? How many 5 to 10 years ago? More than 10 years ago? And the I still need tos. All right, so if you still need training, you can sign up today. It's a nice little thing where they let you work with a rubber model. It is absolutely not something you need formal training for, but because this is a contraceptive and we live in the United States, the FDA requires you to go through 2 hours of training in order to get signed off. But again, it's like placing an IV without having to hit the veins. If you want to stay in that ABC club, I would say if you're providing pills, please just remember that you should be giving your patients a 12-month supply every time they're getting the pills. California and Washington both require our health plans to cover 12 months at a time if people want this, because we have very good studies that show if you give your patients a 12-month supply, they miss less pills and they are less likely to have unintended pregnancies. I take this to thinking about all medicines I prescribe to try to be really mindful. Having to go to the pharmacy is a pretty big barrier to actually taking the pill. We talked briefly about secondary prevention with emergency contraception. Again, we have a prescription pill. And I would say we also have the option of placing an IUD. Placed within 10 days is going to be at least 10 times as effective as the over-the-counter pills. I would say in many internal medicine neighborhoods, we're really good about talking about PrEP and making sure our patients are getting their pre-exposure prophylaxis for HIV. And that is really important to do. What I would ask you to take away with that is remember, if she's going to be at risk of exposure to HIV and she doesn't have another contraceptive, she's also going to be at risk of unintended pregnancy. And so she should probably be getting her emergency contraception to go along with that. I tend to always have a couple people by chance in the audience who, when I say emergency contraception, they say, do you mean abortion pills? And so just to be clear, no, emergency contraception plan B, those are pills that are used within 5 days of sex before the sperm and egg come together. They basically make the ovaries go to sleep, so an egg is never released, so the sperm die trying to find it. And so no sperm gets the egg, no pregnancy gets conceived. It's not an abortion. Plan C, or the abortion pills, are also options and something that many internists have learned how to provide over the last 20 years. If you aren't doing that and you want to get your patients pills, there is this website, plancpills.org, which can provide state level guidance on how to get pills anywhere in the US. But basically, it's a combination regimen where you take mifepristone and then you let it work for a bit, 1 to 2 days, 24 to 36 hours after that, and then you take the misoprostol to make the uterus cramp and empty the uterus. These pills are safe. They've been FDA approved for over 20 years. I would argue there are many medicines that have been released in the last 20 years my favorites, Paxlovid, Entresto, Jardiance, that we've all learned how to prescribe. It's probably time we also learned how to provide mifepristone. This is definitely something that is within an internist wheelhouse. I like to joke, it's totally internist reproductive health medicine because you can do it with her pants on. You just have to counsel her and hand her the pills. You don't have to do a pelvic exam. You don't need an ultrasound. You don't need any procedural training. You can actually just do this by phone and have the pill sent to a pharmacy. Even if you work at an FQHC, you can do this despite the concerns that are out there about, like, I thought federal funds couldn't be used for abortion. And that is true. And there are ways that FQHCs can provide this service because abortion service is time-sensitive care. And there's lots of reasons why access to medical care just in general should not be impeded, but time-sensitive care really should not be impeded. For those who want to learn more about how to provide these pills, I would say there's another online training you can access that lets you watch some video clips of how to do this counseling. And really, there are a lot of things in medicine that we claim are see one, do one, teach ones, but this is really a see one, do one, teach one. The counseling required is not that hard. I would be remiss if we didn't talk about vasectomy for at least a little bit. I had a total pleasurable meeting earlier this morning with your colleague, Dr. Amory, who's doing great work on male contraception. And vasectomy is also a great and underutilized option in this country. That when patients are sure they don't want a pregnancy in the future is a great option. The place we are doing best in helping our patients access vasectomy in this country tends to be women with breast cancer. They are the ones whose partners somehow step up and get their vasectomies. But otherwise, very rare in this country for men to be stepping up, which is just a cultural phenomenon. In places like New Zealand, almost half of men end up having a vasectomy by the time they become groups. So we've covered a lot of ground. My take-home points for you are whatever you found interesting. Hold on to it. And otherwise, if what I was going to ask you to do, it would be that one key question. Does she actually want to be pregnant or not in the next year? And how is that going to orient the care you're going to provide? When you're talking about risks, think about balancing the positive and negative frames. Discuss the absolute, not the relative risks. If you are working with women who have conditions that may make pregnancy particularly risky for them, or you're inclined to prescribe medications that would be teratogenic, make sure you know how to offer Nexplanon because it's an easy procedure and then you don't have to worry about it and she doesn't have to worry about it. Discuss the option of IUDs, find a colleague who can place them. Remind your patients if they like the idea of self-determination, they can remove the IUD themselves. Make sure our patients know that they don't have to have a permanent surgery in order to have their most effective contraceptive options. And that's particularly important because we do so many of them in this country. And because 1 of every 5 women in this country who undergoes a tubal surgery later goes on to say she wishes she hadn't, which to me is a little bit of a horrifying number. Better than it used to be. It's come down. It used to be 1 of every 4 women who had those surgeries wish they didn't. If you're prescribing pills, make sure they only have to go to the pharmacy once a year. If you're wanting to get them emergency contraception, Ella is the better choice. It's twice as effective as Plan C. And think about getting to the point where you're comfortable providing abortion pills, mifepristone, or getting your patients access to Plan C. Because I think for me, it's really changed my ability to help my patients make the decisions for themselves and feel comfortable saying, you use the contraceptive that works for you. If it's less effective, we'll deal with pills for an unintended pregnancy. So with that, I think we get to wrap up by saying I shared a number of web resources with you. The battery is running low here, so we'll see if we can show those before. There it goes. Okay, it has finally advanced. I'll put it there, say thank you. Happy to take any questions you may have. Thank you all for taking care of all of the patients you take care of here. This is a really impressively large medical center. Yes. Oh, I'm repeating the question. Tell me if I'm doing this wrong. The question was, what about talking to our patients about vaccines? And should we be talking about relative risks or absolute risks there? And I would say, with the caveat that sometimes maybe the absolute benefit of a vaccine may not be enough to make somebody think that it's worth having the vaccine. And I guess I feel like honesty is the best policy. And I would also say when I'm doing vaccine counseling, I think some of the principles that I rely on from contraceptive counseling as the place to start is really tell me what's important to you in making this decision. And so often it's not what I would have guessed it was, right? So often it, is, I think it's going to cause weight gain. I think it's going to make my hair fall out. I think it, and so you can talk about whatever you want about what you thought was going to matter to them. But if you don't come over to talk about like, well, let's talk about what we know about whether or not this is going to cause weight gain, then we haven't actually had the conversations that they were looking for or they were going to care about. I also am a pretty big believer in the concept of drops of water turn a wheel, and that many times I may just get to be one drop and I'm not going to change anybody's mind. But when you get to have that moment of, you're like the fourth doctor that said that to me, maybe I should think about that. Then you get to say like, yeah, I think you should. And then that can be fun. So I think for myself, that's how I just keep up my patience with like, sometimes I'm just being a drop of water and I'll repeat myself. And I do think it's important to re-engage and recognize our patients go out and live lives and they've had real experiences. They've had real family members who had adverse reactions after vaccines, have had infections that have been deadly or traumatic in other ways. And so the way they're making their decisions on any one given day may be different. So often it's like, no, I don't have time for that. Like, it's just going to be too many more minutes. And if that's all it is, it's like, okay, well, next time we're going to do that first thing. I won't even open my mouth. We'll just get you the vaccine and then we'll go from there. Great question, though. Do you have additional insights on how we should be telling people to do it? Because if you've cracked it, it would be a missed opportunity for me not to learn from you. Yeah.
Even a lot of
Yeah.
Aimed it that way, but that a lot of them would go for it, but yeah.
I hear your concern and just repeating it for those who didn't hear. The concern was like some of these screening tests, the absolute risks are low and people might not go for it. And I'm a pretty big believer in self-determination and autonomy. And I'm like, more power to you. You don't care, don't have the screening. Yeah. Please.
Standards. There are two ways to look at vaccines. Obviously, there's the personal risk of vaccines that you're okay to, and which relates more directly to this concept. Honestly, the majority of vaccines that we have are not for personal risk for that patient. They are for other people. We routinely vaccinate people against rubella. We're not doing that for the person we're vaccinating against. We're doing it for the pregnant person they might interact with and that fetus who might get infected. So you can counsel them, and people often make this decision. It's a very Western/American individualism decision to not get those vaccines because it doesn't personally help me. As a pediatrician, I do say honestly, I want your child to be vaccinated so your friends will be safe, so other people will be safe, so their grandparents. So sometimes you like the individualism talk might not work. The community talk also might not work, but you have to also counsel that. Like the COVID vaccine, the flu vaccine. Probably everybody in this room got their flu vaccine if they're eligible for it and safe to get. Most of us didn't get it because we thought we were going to die this year, right? We got it because we were. So it's okay to say the individualism, sure. You can say tell them the data about themselves. I would also tell them the data about people who died. A lot of people like you're a hero. You're protecting people. So I just wanted to like there's the focus on individualism is frustrating. I have pediatric folks thinking about that. When we think about less adults and like.
I love those thoughts, very well spoken. To summarize for those who were listening through the mic, we'll let it go. All right. The message was come in person. You get lots of extra details. But I would just follow up and say, I think this is the difference between policy and being a clinician. And I think it's kind of almost never right to set policy at the bedside. And we need to set policy when it's a community benefit at the community level. And I would say, yes, most people got their flu shots because maybe they were community minded, but I bet it was also required or they had to sign out to do this job. And that's a policy decision. And so I think it's important for us to be mindful about where our health policies are and all of these things. And yes, I know it's a complicated time. And I also know we're over time. Thank you all for being a great audience.